So welcome everyone to our special interest group webinar on inpatient child and adolescent psychiatry, and thank you for joining us today. I'm delighted to be chairing the session today. So I'm very pleased to introduce my colleague, Dr. Bode Akintan, as today's presenter for our webinar. Dr. Bode Akintan is a child and adolescent psychiatry at the Hospital of Sick Children and assistant professor at the Department of Psychiatry at University of Toronto. He graduated at the University of Jos Medical School in Nigeria. He then completed his training in psychiatry at the University of Maryland Medical System and went on to complete a child and psychiatry fellowship at the University of Maryland Shepherd Pratt Hospital program in the United States, serving as chief in his final year. He then moved to Canada and was appointed assistant professor at McMaster University and was working at McMaster Children's Hospital for over a dozen years, serving as medical director for the inpatient service and emergency psychiatric services. Then moved to the University of Toronto to take on a faculty position as a staff psychiatrist at the Hospital for Sick Children, Sick Kids, where his primary clinical responsibility is on the inpatient service. At the end of this session, Dr. Tiago Gatti-Pianca, who is a child psychiatrist from Porto Alegre, Brazil, will also join us to talk about practice and personal experiences in his country. We're going to explore the unique challenges and therapeutic approaches involved in supporting young people in acute mental health settings. We're going to discuss best practices, multidisciplinary care, and strategies to promote recovery and resilience in children and adolescents. So we would like this session to be helpful to explore practices in different countries and settings and to have experience and practice sharing with all of you. We're very excited to have Dr. Akintan and Dr. Tiago with us, and I'm sure this will be a very informative and engaging session for all of you. Please note that you can leave questions along the presentation and they will be answered during the question and answer session in the last 10 to 15 minutes. Please join me in welcoming Dr. Akintan.
Morning. So welcome. Good morning, good afternoon, and good evening to you wherever you are joining us from around the world. Thank you for the introduction, and it is a true pleasure and honor for me to be here. I'm speaking to you from Toronto, where it is 15 degrees below zero, and it's still dark outside, so it's a bit chilly here. I hope that over the next 45 to 50 minutes, we can situate ourselves in a position that optimizes our commitment to moving this discussion forward and moving the special interest group forward. Today, I'm speaking to you both as a child psychiatrist and as a coordinator of the special interest group on inpatient psychiatry. And this session is about shared reflection across systems, not exporting any single model. Next slide. Can you see the next slide? Okay. So the 19th of June is the day that I got the email. I got an email from the IACAPAP committee to set up a special interest group, and it was a fortuitous email. I obviously made the application. I was quite happy with it, but then it made me recognize the responsibility to try to gather people around and have a conversation that I felt would be of value. And naturally, you look inwards and you wonder, why me? Like, wait a minute, what do I know about this, and why do I have this responsibility? And as Dr. Perrin shared earlier, I thought it was probably helpful to share my inpatient CV to put myself in a position where there could be a recognition of some of the experiences that I've had, even back to my training days, where I started as a trainee in Maryland, and my last 6 months were really on the inpatient unit. And that's where I got a love for inpatient psychiatry. And so that was back in 2007. And shortly after my training, where I had worked in an acute inpatient urban model, I felt that I had some interest and some experience in that model, and I felt I could go on to do this. I went on to McMaster and the inpatient unit there had not been developed. So it was developed in 2009. So I was helpful in developing the program, and over time took leadership roles in there as the medical director of the inpatient unit, where we really focused on quality improvement, safety integration. So I was able to see it from the ground up. And so after doing that, or at least while doing that, I also had another opportunity to provide inpatient care to a northern hospital here in Northern Ontario. The unique thing about this was it was a model that hadn't really been practiced before, where inpatient psychiatry was offered virtually. And so I've been doing that for the last 10 years, and I'm going to be doing a paper on just our 10 years of providing virtual inpatient care to a relatively low resource area. I serve as the medical director of that unit, and it's really a model that I had also shared during the last Congress in Rio about providing virtual care for resource-limited regions. And moving from there, after a brief stint in private practice, I went to Sick Kids, where I have been providing care at a tertiary quaternary care hospital, Sick Kids, here in Toronto. And it's a high acuity pediatric mental health service, and it's multidisciplinary. And I think for people who work in settings similar to this would recognize some of the tenets of practice in this environment. What I have done in the last year has also been quite interesting. I was, as a function of an educational grant that we're fortunate to receive, able to go to Lviv and help there in the development of a inpatient unit located in a general hospital, which again was novel for them, and really helping them develop the system from the ground up and trying to build in some foundational elements of care there. So in some ways, I felt like, in addition to providing consultation to pediatric units outside of Canada, within Canada, I've been able to consult to BC Children's in Vancouver. I've consulted to the Ontario Ministry of Health. So in some ways, I felt a bit of a familiarity with this space. Why does this conversation matter? It matters because the reality for all of us is that we're seeing rising acuity and complexity of the patients that are presenting to us. And inpatient units generally seem to be absorbing system failures and their work strain challenges across the workforce, be it nursing, social work, even physician workforce strain exists. And the length of stay is increasing. We are not seeing a proportional outcome gain in terms of the patients that we're seeing. And so it really is a moment for redesign, and not just expansion. It's not just more doctors, more nurses, more social workers. It really is, how do we think about this differently? And these pressures are global. So even in high resource settings, arguably Sick Kids will be considered that, inpatient units are absorbing system failures. And these are system failures elsewhere, and it's creating strain, a significant amount of strain, without a proportional outcome gain. So today I'm hoping that we can just have some very broad objectives, recognize that these are shared global challenges in inpatient child and adolescent psychiatry, and try to understand how our local context shapes the models of care that we provide. And we'll talk about some core principles of effective inpatient care and explore future-oriented directions. Where do we want to go from here? And I hope it's an opportunity to reflect on our own system and just think about the care that we provide and what guides it. These objectives are intentionally broad. The goal here is to offer a shared framework rather than prescribe any solutions for any particular system. Now, in thinking about this, we'll have to think, what is the ideal? What is an inpatient unit meant to do? We would imagine, acute safety and stabilization, provide some diagnostic clarification, provide a short-term therapeutic containment environment, probably create an opportunity to engage with the family and figure out what their needs are and try to meet their needs as easily as possible. And hopefully do a clever and methodical transition back to community care. This slide is supposed to anchor us in first principles. These are the things that we would hope an inpatient unit can do. And in this context, inpatient care has a very defined purpose, and many current tensions arise when admissions drift away from this purpose, right? But what are they actually being used as? Right now, most inpatient units are crisis containment settings. It's almost like the default placement when the system has failed. I have residents and I share with them there are often really three reasons why patients get admitted: either the development of a new mental illness, an exacerbation of a pre-existing mental illness, or a system failure. And the system could be the family system, the community system. But by default, patients will come to us and we have to absorb those system failures. We also consider them risk management environments because that is just what they end up being. I think many people can probably identify with social admissions where you're finding that you're having patients who just can't be discharged because for some reason or the other, there are limits to where they can go, either because of the community or the region where you are, or it seems like the right thing to do versus the clinically expedient thing to do. And I would argue that many of us are seeing patients with longer stays and with unclear purpose. And I recognize here that I'm naming what many of us experience, but rarely say aloud. Inpatient units often function as default solutions for system failures. And it's unfortunate that that is the way it is, but we're solving problems that are right in front of us. So I want to do a poll. So could you put up the poll, please? Yeah. What best describes your inpatient context? I would like to understand who's actually in the room and just remind us of the fact that inpatient psychiatry means different things to different people. We'll give a few seconds for people to vote. Okay. Do we have the results? This distribution is exactly why conversations like this are so challenging and so necessary, really. Any model that assumes one of these contexts as the default will not translate well into the others. And so as we move forward, I'd invite you to hold your own setting in mind, but also stay curious about what might be transferable across contexts and what is clearly not transferable across contexts. You can close the poll now. Thank you. See. Okay, so what are the shared challenges across our systems? We are seeing increased severity at admission. We're seeing a high degree of comorbidity, either with the autism spectrum or with concurrent disorders with substance use or with intellectual disabilities. We're seeing a lot of comorbidity. And the impact of this is a lot of distress on the families, their staff moral injury because they feel like their setting isn't adequately suited to meet the needs of our patients. And so they're feeling like, oh, my license is at stake. I can't do this. It's the ethically wrong thing to do. It's a moral wrong thing to do. And so these are conversations that most of us who have either been in leadership or in frontline have been dealing with for some time. And part of the goal of any inpatient program is to transition patients smoothly either to a next level of care or back to their families. And many of us are seeing that these are challenges because those settings aren't adequately resourced to meet the needs of these patients. And I think as you look at these challenges, they cut across systems. And so despite our differences, depending on where we're working, these challenges recur across countries, across regions. So they suggest that they're structural problems, not local problems. So it isn't unique to your setting, your hospital, your community, your country. These are structural issues that are important for us to talk about. Here's where we do differ. Our financing and insurance models differ depending on the country, depending on the nature of the healthcare that you provide. The legal frameworks within which we work differ. And the availability of step-down care is also something that's unique to our different settings. And the way people view hospitals, like what the role of a hospital is, in my practice, I would often share with folks that I consider hospitals part of the continuum of care and not the final destination of care. And so when parents have their children in the hospital and they feel despondent and feel like this is a failure, something bad has happened, I have to reframe them and say that this is what we do here as part of your ongoing care. There are times when you need the hospital, there are times when you would not need the hospital. Excuse me. And I think where systems also differ is in the role of families. And this comes up in relatively low resource settings where families step up and they do more because they have to do more, because that's the reality for them, right? And context matters. So financing, law, culture, service availability, all of this shape the inpatient care, and it shapes what inpatient care can realistically do. And so there's an expression that I grew up learning, that nature abhors a vacuum. And so if there is a space where needs are not met, inevitably someone steps up, a system steps up to try to meet that challenge. And in many settings, that is what we do. And so the local realities shape the care that we provide. And I wanted to group this, and this is not an absolute grouping, but I think different people in the audience might identify with different settings. And so I've grouped it into three different settings: the high resource settings, the medium resource settings, and the relatively low resource settings, hoping that this section shifts us away from comparisons and really towards an understanding and recognizing that local realities are design conditions. And this is important. Local realities are design conditions. They're not deficits. In high resource settings, we have multidisciplinary team. Here at Sick Kids, we have an OT, behavior analyst. We have a bunch of folks. And so we have specialized services. We have neurology, we have endocrinology, hematology, oncology. And so there is an ability to get services from our colleagues across the whole. And in addition to that, there is a governance oversight that has its benefits because it does set direction for us, and it provides some guidance for high resource settings. But in reality, there are also some major strains. Bed pressure is a strain. Our colleagues not understanding the role that we play and not understanding that there are certainly some things that are appropriate for inpatient units and some things that aren't. These are important things to consider. And because of the level of oversight, because of the legal structure that exists, many physicians, many clinicians practice defensively. And this defensive practice is, I don't want to get sued, I don't want to lose my license, I don't want to get reprimanded. And so you're seeing that play out often in high resource settings. And this translates to some extent to delayed discharges, hiccups in care, really, where people aren't doing what they probably ought to do because it is seen as perhaps contributing to something that might expose them or put them at risk. So although high resource settings appear advantaged, resources alone do not ensure that this aligns with their purpose. In middle resource settings, there's a growing demand because the knowledge about mental health care is increasing, depending on the models of revenue financing for the hospital. There are hybrid care models where there's public and private and people pay out of pocket. And because of the opportunities that people who have the resources have to be able to get access to care, there's uneven access, right? And so people that are highly resourced can get the best doctors, get the best hospitals, get the best tests. And I think as a parent, you would do that if you had the resource. However, people who may not have that resource don't have that access. And so there's an expression again that I learned very, very early on. It was in reference to insulin, but it's starvation in the midst of plenty. So you're surrounded by these resources, but you don't have access to it because you just don't have the resources to make yourself, to avail yourself of that resource. And in middle resource settings, families now start to step up. You see a stronger family involvement because it just is what is required to supplement whatever it is that exists in the community. And one of the things that I will say about middle resource settings is that there's a nimble nature to the practice. There is a way that innovations come up because they have to solve problems, and people are thinking on their feet because they don't have to varying extents, they don't have a level of oversight where it's like you have to do it this way, otherwise there's going to be the recourse, and so they can solve problems rather quickly, and innovation comes from this tension. So middle resource systems are often highly adaptive, and innovation emerges from necessity. In low resource or emerging systems, there are often very few dedicated inpatient units. And this is where you really see true innovation and creativity, because you see task shifting. You see a physician who's also an administrator. Back in Ukraine, I remember a few of the physicians saying they were calling the patients to schedule appointments and doing a number of things that in other resource settings may have been delegated, but it allowed them direct access to the patients, and it allowed them to really get a feel for what the limits to the patient's presentation in the hospital were. So the task shifting has its advantages. And in these settings, families often lead care because they are the ones at the forefront. They are the ones who are making the decisions. They are the ones who are often having to get all the resources that are required for the patient to get care. And all they're looking for in the hospital setting is the expertise. So they're creating the resource, they're buying everything they need to buy and asking all the questions. And although middle resource settings can be adaptable and open to novel innovations, low resource settings are really very creative, have to adapt to shifting, the shifting landscape. Sadly, though, in spite of the creativity, in spite of the adaptability, there's a high unmet need. And so low resource settings highlight creativity, but also the ethical tensions when patients' options are limited. And these ethical tensions aren't to be dismissed, right? We have to think about how we manage safety. If in a high resource setting I can get 2 staff, 1 security to come and monitor the patient, I may not get that in a low resource setting where I have to say the family should do that. And the way the family would exert their authority or their effort at creating safety might look very different than if I were in a high oversight, high resource place where there were certain guidelines in terms of what I could do. And what we would call therapy in some contexts or containment in some contexts, I think it's important to think, what is it that we're really exposing patients to? Again, creativity, adaptability, all good things, but the reality is that it comes at a price. And these beds are not plenty, right? So there are very few resources, very few beds. And with these scarce beds, you have to think who has access to them. And is it what are the elements of the decision making around who has access to these beds? And is there any form of equity around who can get access to these beds? And whose problem is being solved? Sometimes you're solving the family's problem, sometimes you're solving the patient's problem, and sometimes you're trying to solve a system problem. And it really isn't always clear whose problem is being solved, but those ethical tensions exist, and they exist because in a situation where you have probably relatively modest oversight, but high need and low resource, you are going to have those ethical tensions that you have to deal with. I want to ask another poll question and just an honest reflection. So can you put up the slide? Yeah. In your setting, inpatient care most often functions as what? Therapeutic stabilization, diagnostic clarification, crisis containment, holding space, or a mix of all of the above. We don't often ask this question explicitly, not because we don't know the answer, but because it can feel uncomfortable to name. Okay. Let's see what the results are. Aha. In my own setting, the honest answer is mixed as well. The risk arises when we describe inpatient care as doing one thing, while it is functioning as doing another. So that gap between intentionality and reality is where a lot of moral distress lives. And I think inefficiencies live here, frustration lives here, but it also is where opportunities arise. And this is where the opportunity for redesign sits. It really is an opportunity for us to think about what it is that we're going to be doing differently. But yes, for me, it's also a mix. And so what actually works? What do we know that actually works? And it has to be based on principles. The core principles of psychological safety: how do we create a safe environment for people to do their work? How do we have a rational way of containing the individual? How do we make sure that people are safe? And how do we make sure that whatever setting we create is appropriate for the child? While I was at McMaster, we had a unit for the children, 10 and under, and then we had a unit for, 12 and under, and then we had a unit for the teenagers. And we needed to do that because the needs of an 8-year-old on an inpatient care is going to be very different from the needs of a 17-year-old on an inpatient unit. And the role of families: can families sleep over? Can families be part of the treatment plan? Can families help dictate the treatment plan, or at least help create the treatment plan? And having a clear purpose for admission. I think the certainty of purpose for admissions is an underrated element here, because often inpatient units are just trying to respond to the needs of the community that they're in. And so here, safety isn't just a physical safety, it's a relational safety, and it's foundational to any therapeutic containment. Development matters. Ignoring it risks you providing custodial care rather than therapeutic care, and I think that's a very slippery slope. And families are central partners in any decision making, in even regulating their child and making meaning of it, because what it means to the family is what they're going to communicate to the child, especially if the child does not have the wherewithal to understand what's going on in their environment. And so if this has meaning to the family, it will have meaning to the child. And that is an important element in the process of recovery. And building safety through relationships, creating predictability for the child, having consistency with the staffing, and providing, trauma-informed care, and trying to reduce the amount of coercion, because I think that often families come in frustrated. I would often share with my residents and patients that I'm seeing them in what they would argue is the worst time of their life. And so they're very vulnerable, and many times they're just open to any suggestion, and it's very easy, it's tempting at times to force one's values on people because you feel it's the right thing to do, or it's coming from the right place. And so it's really important that we have to develop a safe relationship so that our efforts do not seem to be coercive. Having a developmental focus is important because children are not small adults, and child psychiatry is not small adult psychiatry. And in one of the places where I work, the staff often would work on an adult unit on Monday and could very well be on the child unit on Tuesday. And I see the tension because they come in there and their mindset is still an adult. Their mindset is still, this person did this intentionally, this person was trying to harm me, this person was trying to be, a variety of things. And one has to now change their mindset and say, for a 10-year-old, this is normal. This isn't about you. This is about a 10-year-old who developmentally, this is how they view the world. And you're doing that for one person who's going to end their shift in 8 hours, and then the following day you have to do the exact same thing all over again. So I think it's important that as inpatient units, we have a developmental focus and recognize that we're working with children whose developmental stage is at a certain point that we are now responsible to meet, so that we can meet their needs. Having a sense of any neurodevelopmental challenges that the child may have, to a great extent, creates an environment in which you can now appropriately address some of the challenges that the person has, creating an opportunity for, school, for play, for adolescents who are just forming their identity and trying to know who they are. I think these are important constructs that need to be part of the thinking around how we provide care to our patients. And most importantly, at least to me, very, very important, is cultural context. In the northern communities where I work, where I provide my virtual care, there's a level of awareness that I have to the disparate cultural differences that we have. And because I really want to pull in the families, it's important for me to constantly think, how do I create a partnership with the families that I'm working with. And the minute they walk in, I'm trying to engage them early. I'm calling them in for a family meeting. We're trying to share my understanding of what's going on. But I always defer to them and label them and call them as the experts of their child. I have simply been invited to provide and participate in the care of this child, but I'm by no means the expert of that child. And I think just that framing welcomes them to be part of the treatment process, welcomes them to be to be at the table, to have a conversation, and my recognizing their distress and framing it as a treatment target helps them relax and really allows them to lean into the care that we're providing. Very often I would say to them, and again, for the indigenous communities, I say to them, I don't know anything. And this is after doing it for 10 years, I still lead with, I don't know anything, because I have to start with the learner's mindset. Not just from a cultural standpoint, but just, I don't know their family. I know zero about their family when I'm meeting with them. And I think that has been helpful. And I think for most of us who are practitioners, that mindset of coming in and saying, I don't know anything about you and I'm here to learn it, and I need you to partner with me, can be a core principle that I think would allow us to be better providers. The other thing that I think is important is how do we bridge that interface between inpatient care, which people consider specialized care, hospital-based care, with the community? And how do we bridge that interface, right? And the way, I mean, some settings have done that is the minute you walk in, I'm thinking about discharging you. I'm thinking about where you're going to go, what you're going to need from the minute you walk in. And so those conversations can start early. And because they start early, they really create an opportunity for a healthy discussion about how we can make a soft landing for you when you leave the hospital. And so it allows for really rich conversations with people in the community, really rich conversations with other service providers, and really creates an opportunity for shared responsibility for care. So it's not as though, I'm an outpatient provider, I've admitted the patient, they're off to the hospital, whatever they do in the hospital, when they're done, I get a discharge summary, and that's it. Drawing them in early, having that conversation with them really creates a shared opportunity. And I will say to some doctors sometimes, if you were me, what would you have wanted to do in addition to the work that you're doing in the community? And so they can say, well, there was this test that I was curious about, or there was this thing that I really wanted to do. And so that kind of conversation really allows you to feel like you're part of the care as an outpatient provider. And it really limits this revolving door element of inpatient care where people come in, oh, they're getting admitted again, oh, they're frequent flyers. And so instead of seeing this as a game of going in and coming out, we really see ourselves on an inpatient unit as connectors. Who else in the community should be part of this conversation? And so once we can really create that inpatient community interface and use the bully pulpit, as it were, to invite people in and to have those conversations, I think we further the care of our patients and we do them such a service. Because inpatient care cannot function in isolation. Transitions are clinical interventions. They are clinical interventions, and work must be put into ensuring that this is a priority. Because when we lose that, we lose the opportunity to really create a really important bridge for folks that we care for. So as we do this, I want us to reflect on, your most recent admission. And what problem was it really trying to solve? Was it a clinical problem? Was it a system problem? Was it a social problem? And this could be an admission you had today, depending on where you are in the world, where maybe your day is ending, or one you had yesterday. The most recent admission, whatever problem it was trying to solve, is a problem that needed to be solved. And sometimes it's as easy as making a diagnosis. Sometimes it's as easy as finding out what the challenges with the system are, or what role are you playing in terms of trying to address a social problem. And so this reflection is really for internal clarity about what inpatient admissions are solving, not specifically for saying, here's what we want to do. So looking ahead, I want us to just reimagine inpatient care, right? How do we reimagine it as shorter, purpose-driven admissions, creating a step up from outpatient, a step up from day treatment, a step up from whatever service is not hospital-based into the hospital, and having a reciprocal model where from the hospital, because we've created such important partnerships, we have step downs. How do we make sure that the home hospital hybrid, what services can be provided at home, what resources can be offered at home, either from the hospital or from a service that is driven by what the hospital provides, so that this avoids unnecessary admissions? Is there a way to engage families virtually? In the Northern project that I've been doing for the last decade, I do see patients virtually. I see them virtually all the time. And so I'm automatically engaging the patients virtually as well. And for many folks, this is a big element of care, because resources are limited. The amount of resource that has to go into moving to the hospital for a visit, for a meeting, is enormous, and it's an enormous strain on many families. So we can't ignore that. And I think as we think about inpatient care, we have to see the inpatient unit really as a system hub. What resource can we garner? What can we do? How do we create movement in many of these services outside of the hospital? And reimagining inpatient care means redefining its role within the broader system. Not just responding to the needs, not just responding to the pressures, really trying to say, how can we do this differently? And it might mean that, we look at a workforce redesign. We look at expanded roles. I talked about what happened in Lviv, Ukraine, where the staff psychiatrists were doing some other work, where nurses can recognize the role of child and youth clinicians, recognize the role of social workers, and provide care in that context. What role does nursing leadership have? Are there opportunities for peer or youth groups where they can inform the care that's provided on the inpatient unit? And what kind of family support exists? And how can we train for complexity? Because in many ways, complexity is the norm. Complexity is what we deal with day in, day out. So it isn't so much that we now have this other layer of patients that are complex. All of our patients are complex. And so we have to now position ourselves to be able to recognize and absorb that complexity and provide care in that context. We can't do this without recognizing that our staff well-being is paramount to providing good care. There's a book that I read recently, Patients Come Second, a very provocative book, but it really was not speaking to the patients literally being second in line, but thinking, how do we make sure that the staff who provide care are well cared for? Because then they can provide better care, they can provide safer care, and the patients are the ones who benefit when the staff well-being is considered a key foundational element of creating a safe environment. And so workforce sustainability is a safety issue. Without it, any redesign effort will fail. And it's not out of scope work. It's really working within scope, but stretching yourself to the margins and making sure that you're providing care as creatively as you possibly can. And finally, for those of us in the research world, we have to measure what matters. I think we have to go beyond length of stay and bed occupancy, which are traditional things that we've used historically as ways of evaluating the quality of the care that we're providing. In some facilities we have worked, we've weighted the patient's severity and said, all right, so a patient with an eating disorder and depression weighs more than a patient who comes in with an adjustment disorder. So, how do we move beyond that and look at functional outcomes? How do we look beyond whether the patient was suicidal at a certain score and then they're no longer at that score? I think by definition, the score will be lower. But is that really what it is that we need to measure? And is there a way that we could measure her family confidence in the care that we're providing? Is there a way that we can measure how effective we have been at system integration? Is there a way that we can measure the readiness for transition to another level of care? I think thinking about these things and thinking about how we can measure them really opens up a whole door for researchers around what are the things that we can do that would be an accurate reflection of how we feel that our care is better. Because I think for most of us clinicians, there are times when you've provided care and you feel that it's better, but you can't measure it because we haven't yet, found objective ways of measuring those things that intuitively you know are better. And here's where I would say is really important, because measurement signals value. If you measure it, it's important to you. And so throughput, the number of patients we see every year, it misses meaning. Each program needs to identify what it will measure, because what it measures is what signals what it's valuable to them. And so regardless of where you are, low resource, medium resource, high resource, what you measure is what you're communicating as what matters to you. And I think it's really important that we have that in mind, so that for research purposes, we're thinking generally about what it is that we really want to do for our patients. I have an optional poll. Perhaps Sue, maybe you can put that up. I'm curious to know what folks feel would have the biggest impact in their system, whether it's more accessible community services, shorter admissions, increased staffing, more family involvement, or just having clearer criteria for admissions. We have our results. Yes. Again, the jury has spoken. We need to be able to make sure that we have the resources in the community, because that is what allows us to have a good transition out of the hospital. And also, if they're more accessible, then the way that they come into the program would also be smoother. So I think these are things that, whereas, yes, we would prefer to have shorter admissions, it would be nice to have increased staffing, having greater family involvement. All of these things are important, but making sure that there is a safety net for when the patients leave the hospital. So it's a reverse thinking from where we consider the inpatient unit as a safety net to really thinking about the outpatient programs as a safety net for our patients. Thank you. So I think that, can you hear me?
Yes.
Okay. Yes. So thank you, Dr. Pianka. Thank you, Dr. Shudi. As I mentioned, I work here in Toronto, and I know that you're in Porto Alegre in Brazil, and Dr. Shudi is in Australia. And I'm curious to know how you're finding your practice, what kind of challenges you're having, what type of things that you're faced with, and how you're generally interfacing with your population.
Dr.
Bianca?
Shodi, you are
Yeah, I was just going to say, maybe I'll just jump in first. First of all, thank you very much for that very lovely presentation. Where I'm coming from, I found myself working in a lower resource setting before coming to Australia, which is a higher resource setting. And so very clearly, one can easily see the difference in the strengths and challenges faced. So, and like you said, our practice in inpatient settings cannot run away from the context in which we practice. The context in which we find ourselves will influence what we see. For example, you highlighted the role of parents and family in care a bit deeper in middle and low resource settings compared to the high income settings where you have a lot of funding and human resource. But nonetheless, those settings have their different challenges. I'll just say that there are a few challenges. A lot of crisis admissions, crisis containment, is generally seen. And we must reimagine a few things. And yeah, probably we'll have a few thoughts on that. So I just thought I'll just mention that, yes, the context specificity of what we see as a strength and weakness will always be evident. Dr. Tiago?
Okay, let me add my experience on this. Here in Brazil, we, as a general rule, are in a low, how do you say it? We don't have a lot of resources. Yeah? We have a low resource setting overall in all the country, and inpatient admissions, inpatient units for child and adolescents are quite sparse on all the territory. We have whole states without one single unit for child and adolescent psychiatry. So that's a good reality we have around here. But I have the luck and privilege of working in a unit that is well established and quite well funded compared to the rest here in Brazil, which is here in Porto Alegre, because it is first of all it's a clinical setting inside university hospital. So we have funding from university and not just from the health system. And also it is a mixed unit that has both patients from the public health service, but also from private insurance companies sharing a number of beds. It's a small unit. We have just 7 beds, but those beds are shared between those two resources, I can say like that. And the money that we get from the insurance, health insurance companies, it kinds of increments the overall funding of the unit and the hospital as a whole to have better care for those who don't have the insurance systems and rely on the public health system here in Brazil, which is quite good and universal, but it's always underfunded, as you would expect for such a thing. We have a good unit, but it is relatively new because even being inside a tertiary hospital, university hospital, we 4 years ago we didn't have this unit. We had I was mentally answering the post questionnaire that Dr. Akintan made for us, and I was just thinking, wow, we now have this beautiful and good unit, but it's just 4 years old. It was in 2022 that it was created. Before we had beds in general infirmaries, general units here in the hospital. We had a few beds here and there, and beside our patients with suicidal ideation, we had another who had bronchitis and clinical settings overall, and we had a very bad care because we didn't have staff properly trained for that. And this, what we had before, is the reality of my country overall. We don't have units, a few units, and those units there are, say, specialized in mental health for child and adolescents have very bad quality overall. They have low staffing and all kinds of problems. Not just that, but I would say that thinking about the biggest challenges we face here are just the problems with continuing care for after the treatment. We mainly take patients in crisis and needing readequation of treatment, and then when we discharge them, sometimes we don't have anywhere for them to keep their treatment, and this is quite a challenge, and this is what make it become quite a revolving door, like mentioned in the talk. I don't want to monopolize the discussion, so I'm stopping here.
I'll have just wanted to add something to what Dr. Bode had said, because I kept wondering about the role of, or the risk of iatrogenic harm that all our inpatient services, presents, because especially when they're being used for crisis containment, it's important, I think, as clinicians, and I see that a lot, having moved here to Australia, that we need to continually be mindful of that harm that inpatient admission can actually do to some kids. So we need to see how to shorten the stay, reduce the admissions where possible, except it's for people that really need it, and try and encourage community in-reach. That's something that I found that works very early. So that handshake with the community exists even from inpatient, and then the continuum of care is put into place. One last point that I found helpful working here is when we plan the admissions, rather than coming through the ED, it's a bit more contained, and the outcomes seem to be a little bit more within our control, if that makes sense, because the kids, they understand they're in for a short period of time. We have goals that we've agreed on as a team and with the patients. So these would be maybe the additions I'll add to some of the things you mentioned that I found very helpful working in this setting, and I found, could be useful. Thank you.
Yeah. Although I work in at SickKids, so I also provide care in a relatively low resource setting, and the social worker is she in this case is the glue. That unit will not exist without her, and she is an extraordinary resource because she recognizes that as a philosophy, the foundational philosophy of the care that we provide there is advocacy. So every unit I've worked at, I've said, we need to have a foundational philosophy. And the role here is that we're working with the most vulnerable people in our country. And so how do we make sure that we are their voice? And so consistently, and I've challenged them, if I am not advocating strong enough, challenge me on it. And so we'll come to rounds and they'll say, Dr. Akintan, I'm advocating for this child not to be discharged today, and here's why. And so empowering the folks that you work with to try to recognize that what is it that we're going to say our identity is, because we are working with the most vulnerable people in our population. And so in whatever setting you're in, and in this setting, it's a low resource setting where if there's anything that we can do is advocate for them in the community. So we're calling people, we're using our bully pulpit. We're literally calling people and saying, come to the table, we're going to have a conversation. And so they're like, oh, the hospital has called us, so we have to take it seriously. And I think even if that's all we do, our ability to do that is profound. And I have found it to be quite helpful. And the feedback has often been, thank you for standing up for us. Dr. Miti?
Yeah, I'm sorry, but I'm going to need to interrupt this very interesting conversation. And I thank you, Dr. Bode, Akintan, and Dr. Tiago Bianca for the contribution. And obviously to Dr. Yuvande Oshodi. It's time for question and answers. We have like 5 minutes left. So I have several, like at least 11 questions for you. So I don't think we're going to have time to answer all of them. So many of the questions are just like to thank you for a fantastic talk, but there are questions such as insisting on how the Pan American Health Organization's Mental Health Atlas has reported that governments in the Americas allocate less than 1% of the total budget to mental health. And what healthcare model would you recommend for acutely ill children and adolescents facing mental health conditions in these regions is one of the questions.
In looking at the questions, I think if anything at all, this is a plug for the special interest group. And we are going to be having a symposium at the Congress, and I really would hope that many of you are going to be able to attend, because these are important conversations. And what I really want to be clear about is, as we create this forum, it really is an opportunity for us to test our ideas and be exposed to other ideas about how other people are solving those problems. So we are not going to, there is no one size fits all. But I think as we listen, as we collaborate, as we engage one another, there are going to be opportunities for us to learn. And so this is my plug for the Congress in July. For those of you who are able to attend, to come, because we want to have those richer discussions, and it's unfortunate about time, but we really feel like these are things we can dig deeper in a symposium, and I'm looking forward to seeing everybody in July.
Mm-hmm. Another question is, what do you think about day clinics?
I mean, we found them helpful as a step up, step down model. We found them particularly helpful because they can take high acuity patients without the need for hospitalization. And here's another role where parents and families can really lean in and have the patient at home, have the patient continue to engage with the families, and use that as an opportunity for intensive involvement of clinicians, while they also have the benefit of being at home.
Thank you. Then another question is, what is our role as inpatient units in advocating for additional and appropriate community resources?
We have to keep talking. We have to keep making noise. We have to keep advocating. We have to keep doing it. We can't stop. That is all I will say. We cannot stop. We have a microphone, and it's a loud one, and we have to keep using it.
We have to try to mobilize the community, even for resources. And sometimes we can do that, and we have luck to find the people who have the resources to share, and can see our calls as well.
Thank you. Another question, and this might be very relevant for people who are newly starting services. It says, what's the most important thing to newly start the inpatient unit for children and adolescents?
Dr. Shodi, Dr. Bianca, I can speak to mine, but I would like to hear your perspectives.
Well,
What's the most
important things to set up a new child and adolescent inpatient service? That's correct, right? Is that what it was?
Yeah. Yes.
I'd say that it may help to not try and reinvent the wheel. Have an idea of what other models are out there in your region, so that you're not necessarily importing something from somewhere that may not work in that context. Remember, we've said that there are context-specific things that we must consider. And having that in mind, then at least you have a platform to start with. So have an example you can work with, and then try and see what you can model around those things you can see. There's some models that you find that it's a couple of beds on an adult unit that exists in low middle income countries where there's not enough resources. In some places, you may have the resources to have separate units. So I think it would vary based on the resources available to you, financial and human resource. And then what are models that have worked in your region? I'd say that may be a safe place to start. And then you can grow it, based on other things you find useful. Those would be my recommendations.
I totally agree.
Yeah. So I'm just having time for one more question, and I'm so sorry. Okay, so I'm just randomly taking the questions. There's another one, again, thanking you. And Dr. Annie is wondering if you have any thoughts about the work that Professor Hickling did in Jamaica in the 80s and 90s to drastically reduce the number and duration of inpatient psychiatric admissions by using medical words and by using early psychotropic medications to quickly reduce acuity.
Oh, I'm not familiar with the work, but I can speak to just the general principles. I think it really speaks to what we were saying earlier, which is you use the resources in your community to address the needs of your community. And so it sounds like that's the principle that's guiding this, using whatever exists there to try to solve the problems that exist there. And I'll certainly try to make myself more familiar with the work.
Thank you. I think we have to come to an end. just wanted to thank you very much again, Dr. Akintan, Dr. Tiago, Bianca, and Dr. Giovande Oshori for your participation. And it's been really informative and comprehensive session. I just wanted to again remind you of the special interest groups that we have. One is this one, the Inpatient on Child and Adolescent Psychiatry. The other one is Coercive Control. And the third one is International Pediatric Psychopharmacology. So these are the three special interest groups that the IACAPAP has. And then I would like to, again, thank all the participants and the audience. And sorry, we didn't have time to answer all the questions. But I hope the seminar will be collecting all these thoughts and you can share your own experiences with us as well. So I think we will come to an end. Just to remind you, we have the 27th World Congress of IACAPAP in July. So we are looking forward to seeing you there. Thank you very much.